resources to kind of help y'all out with TBI, okay? So, more than 2 million people in the United States sustain a TBI annually. So what is a traumatic brain injury? It is alteration in the brain function or other evidence of brain pathology caused by an external force. So most of these injuries are mild because they're sports injuries, concussions. So the two main causes of head injury are falls and being struck by an object. So what are you going to deal with most in facilities? Falls. And with a geriatric population, what are you going to deal with most? Falls. The third main cause is a motor vehicle accident. So typically this type of injury impacts males more than females. Males tend to push their boundaries a little bit more in life. Did you see me giggle? Okay, so there's traumatic brain injury and then there's non-traumatic brain injury. And this is not in your book. So a non-traumatic brain injury results in abnormal neuronal tissue activity and or structure in one or multiple areas of the brain caused by an internal disease process such as a stroke, a neoplasm, which is a tumor, infection, or anoxia. What is anoxia? No oxygen. So, also note that drug and alcohol abuse can cause a non-traumatic brain injury. The ABI is acquired. Don't worry about that. Just non-traumatic. Via disturbing nutrient distribution to brain tissue, direct cellular damage, altered chemical homeostasis of the brain, and hypoxia.
What did you say before?
ABI, it just means, okay, so there's acquired brain injury is basically the top tier, and then there's traumatic and non-traumatic. So an acquired brain injury, and then there's two types. There's traumatic and there's non-traumatic. So a common diagnosis within the geriatric population that you're going to come across is the ones that impact infection and they get encephalopathy, okay? And a lot of times this infection comes from a urinary tract infection, okay? So if you have a patient that's incontinent, that's sitting in urine, they develop a UTI, that UTI then impacts the chemical homeostasis of your brain, causing encephalopathy. That's why when people have UTIs, you see increased confusion sometimes, right? They could be getting some encephalopathy from that urinary tract infection. And then you'll see patients that have the diagnosis of recurrent UTIs. So they are actually most of the time on a prophylactic antibiotic to try to prevent that from reoccurring because they don't want them to get to this point, right? So think about somebody that has dementia, that's incontinent, that keeps getting recurrent UTIs. This can be a real issue for them. And if they're not cared for properly and they're not cleaned properly, their hygiene is not good, this continues to be an issue. It's cyclical. So when you see that cyclical cycle like that, and you see this patient maybe in a memory care unit at ALF, and they keep getting these UTIs over and over again, that might be a cue for you as a therapist to tell their caregivers, hey, you should probably look at another level of care for your mom. At this time, she continues to get UTIs. She continues to have this issue. The level of care that she's receiving at the assisted living facility is not enough to accommodate her needs. So there's that progression in care that may need to occur.
I know what it's like to perform through pain. If you're like me, one of the millions suffering from pain.
Today's topic is encephalopathy. Encephalopathy is a term describing any disease of the brain that affects the structure and function of the brain. There are many types of encephalopathy, with distinct causes. In some cases, encephalopathy can be a complication of another condition. Some types are temporary, and some are permanent. Some types are congenital, as in present from birth, and never change, while others are acquired after birth, and may get worse over time. Types and causes of encephalopathy. Chronic traumatic encephalopathy results from multiple trauma or injuries to the head, usually leading to nerve damage in the brain. This type is usually found in people who participate in contact sports, such as boxers, footballers, or members of the military who have been injured in explosions. Mitochondrial encephalopathy is a metabolic disorder that is caused by an alteration in the function of mitochondrial DNA. This type can affect many body systems, particularly the brain and nervous system. Glycine encephalopathy is a genetic disorder involving abnormally high levels of glycine in the brain. Hashimoto's encephalopathy is a rare type of encephalopathy. This condition is linked to an autoimmune disorder known as Hashimoto's disease, a condition where the immune system mistakenly attacks the thyroid gland, the gland responsible for producing many of the body's regulating hormones. Hypoxic ischemic encephalopathy is a type of brain damage caused by severely reduced oxygen to the brain, leading to permanent brain damage or dysfunction. Hepatic encephalopathy is a type arising from liver disease. It is caused by a buildup of toxins in the brain that can happen when the liver is not functioning properly. Hypertensive encephalopathy is a type arising from severely increased high blood pressure that goes untreated for too long, resulting in swelling in the brain. Uremic encephalopathy is a result of kidney failure. It is caused by buildup or high levels of uremic toxins in the blood when a person has kidney failure. Toxic metabolic encephalopathy is caused by the presence of an infection or the presence of toxic chemicals in the body that can impact or affect brain function.
Toxic metabolic
Wernicke encephalopathy results from a vitamin B1 deficiency. Vitamin B1 deficiency can be caused by alcohol use disorder, malnutrition, and poor food absorption. If left untreated, Wernicke encephalopathy can result in Wernicke-Korsakoff syndrome. Transmissible spongiform encephalopathy is a collection of diseases all caused by prions. Prions are naturally occurring proteins in the body, but they can mutate and cause diseases that progressively damage the brain. Prion diseases include Kuru, chronic wasting disease, Creutzfeldt-Jakob disease, fatal familial insomnia. Symptoms. The main symptom of encephalopathy is an altered mental state. This may involve confusion, fatigue, forgetfulness, lack of concentration, a changed personality such as behaving out of character, problems thinking or processing information. In addition to an altered mental state, neurologic symptoms may also occur. This may include seizures, trembling, involuntary twitching, muscle weakness, a difficulty with speech or swallowing, rapid involuntary eye movement. Symptoms depend on the type of encephalopathy and its severity. Diagnosis and treatment. To make a diagnosis, the doctor will review your medical history and ask questions about symptoms. The doctor may also carry out tests, including blood tests to detect toxins, bacteria, viruses, chemical imbalance, or prions. A spinal fluid examination. This procedure involves taking a sample of your spinal fluid to look for diseases, toxins, viruses, bacteria, or prions. Imaging scans such as MRI or CT scan to detect abnormalities or damage. Electroencephalogram to measure the electrical activity in the brain. Treatment. Treatment options vary on the underlying cause of encephalopathy. The doctor may suggest medications to slow down the progression of damage, and in some cases treat the underlying cause. Surgery may also be required in some cases. Nutritional supplements may be required to slow down damage to the brain, or a special diet may be recommended to treat the underlying cause. In cases where the brain does not receive sufficient oxygen and you slip into a coma, the doctor may put you on life support to keep you alive. Thank
Okay. That's the best thing I could find for encephalopathy. But, toxic metabolic encephalopathy is one that I see quite often diagnosed in those situations. A lot of times they evaluate the UTI via a urinary analysis. So, and then they'll culture the urinary analysis to see what grows in order to put the patient on the right antibody. So what is the role that you take as the PTA? So you perform interventions that target body structure, functions, activity, and participation. You work with the interdisciplinary team to facilitate a safe discharge, and you consult with your PT on intervention and assessment and discharge. Okay. I went and added some pictures. So, medical recovery issues and mechanisms of injury. So typically with a traumatic brain injury, you're going to have this contra-coop injury, okay? Where, you know how your head is suspended in cerebral spinal fluid. So the coop injury is when you have initial impact and your brain hits that. So if you, let's just say you hit the front of your head, right? So the brain is going to bruise on the front, but because it, what is the Newton's law? Something in motion will stay in motion. So there is the force has to rebound, and when it rebounds, it will contra-coop on the back of my head and hit the back of my head and bruise it or impact it. So it is the rebound impact.
So is that only with TBI or only with traumatic?
Only with traumatic. And then you have this type that's called a diffuse axonal shearing. That's when the neuronal damage is associated with traumatic rotation, acceleration and deceleration of the brain. So that's when your head is rotated and the rebound rotates instead of going this way. It rotates and hits on the sides. It causes diffuse axonal shearing. So think about like a washcloth being wringed out, right? That's kind of what happens when you are shearing, basically. Does that make sense or not at all? So there's two different types of TBIs. There's categories. There's open and closed. So you see how his is closed, there's no skull fractures. And then open, of course, is the involvement of fractures. So the cranium stays intact with a closed injury. And then there's a fracture with an open injury. So what can happen is that intracranial pressure can increase because of the edema caused from injury. And we've talked about that, is there's bone there and there's nowhere for your brain to go when it swells. There's a problem, right? So that's when you get into people getting craniotomies or burrow holes drilled to relieve pressure. And remember, if anything is open to air that shouldn't be out in the air, you are likely to get an infection in that area. So that's why I have that down there, is if you have an open injury, you're more susceptible to infection. And then another medical issue that can occur is hypoxemia. So that's just low oxygen levels. So you're never just going to see a head injury most of the time. A head injury is going to be accompanied by other issues or concerns, because if you think about it, if someone falls, yes, they may just hit their head, or they may break their femur or their tibia or their humerus. You're likely to see something else happen, or if you have a motor vehicle accident, you can have other organ damage that you have to deal with, or you can have other broken bones to deal with. So the head injury is likely to not be the only thing that you have to deal with these patients. So the skull fractures, I'm sorry, this picture's not like the best in the entire world, but there's different types. So there's the basilar skull fracture, which is down here. It kind of looks like a spider web. The depressed, which is what it means, it just makes a depression in your skull. And then the linear, which is just what it means, it has a line in it, makes a line. And commuted just means like there's basilar and there's a depression there, so it would kind of be commuted, it would be both. So another risk in TBI is heterotrophic ossification. Do y'all remember what heterotrophic ossification? I'm not great. What now? Yeah, like bone in areas that it shouldn't be, right? And like the ligaments and the tendons, usually around large joints. You have a hematoma that can develop. What's the hematoma? It is. It's not a bruise. It's blood that's pooled, right, from the area of injury. So it's basically just a pool of blood that's sitting there congealed. Basically, it looks like Jello. But a lot of times the hematoma, it depends on size, of course, but most of the time it's going to be much larger than just a regular embolus or a clot that you would think of.
Is that, you pull those out?
Yes, so that's what they do a lot of times with craniotomies. They relieve pressure not only, but they evacuate hematomas. And obviously one of the issues that can arise from TBI is seizure activity. So what's the recovery position for seizures? On their side. So, I'm gonna talk more about this, but a contusion is a bruise. That's what you're talking about. And it normally happens at a distant site from the initial impact. Okay. So, when you're in ICU, what you can see with these patients is a lot of them are gonna be intubated. They may have multiple IV lines to deal with. You're gonna have an internal, intracranial pressure monitor, and that's what I have a picture of over here. That's what this fella has on him. So when you walk in, you know what that looks like. And then they may have a chest tube or a Swan-Ganz catheter pulmonary artery monitor, and that is this thingy right here that this fella has. So how do they evaluate their consciousness level? They use what's called the Glasgow Coma Scale to do that. It is in your book. It is table 12.1 in Alfred, so it's chapter 12. I'm gonna pull popsicle sticks because I forgot my book and y'all are gonna read it. Do you wanna read it for us, Jazz? You gotta read loud.
Okay, so it's kind of hard to like explain this, but you look at the eyes, and then if the eyes are open, if they're spontaneous, you give it a 4. I guess if they open it to verbal command, they get a 3. And then like, I guess if you put them in like some kind of pain, they get a 2.
It's a pain response.
Right.
You check your pain response.
And then if the eyes have no response, you just give them 1. And then for best motor response, to a verbal stimulus, if they obey the command, they get a 6. And then it goes to like to painful stimulus. So I guess like if they respond to localized pain, is that what they're saying? They get a 5. Flexion withdrawal, I guess if you touch them, they flex back up. They get a 4. It says flexion abnormal. Decorticate rigidity.
Decorticate?
Yeah. I don't know what that means, but you get a 3 for that. And then extension, wow, this is big words. Decerebrate rigidity.
So that's basically when you go into complete extension. And decorticate is the opposite. Okay? So decorticate is flexion, decerebrate is extension.
And then if it's no response to a painful stimulus, they get a 1. And then you got a best verbal response. So if they're oriented and converses, you get a 5. If they're disoriented but converses, they get a 4. Inappropriate words, get a 3. Incomprehensible sounds, get a 2. And then no response at all gets a 1. And then you can score from either a 2 or 3 to a 15. That's it.
Okay.
The new Motorola Razr Plus.
The Glasgow Coma Scale is a neurological assessment tool that is used to evaluate the level of consciousness in a patient who has suffered a traumatic brain injury or other neurological condition. We created this video to cover the medical definition and provide a brief overview of this topic. So if you're ready, let's get into it. The Glasgow Coma Scale is used to measure the patient's responsiveness in 3 areas. Eye opening, which is the patient's ability to open their eyes spontaneously or in response to verbal or physical stimuli. Verbal response, which is the patient's ability to speak or make sounds in response to questions or commands. and motor response, which is the patient's ability to move in response to stimuli, such as withdrawing from a painful stimulus or following simple commands. Each of these areas is scored on a scale of 1 to 5 or 6, depending on the specific assessment method being used, with a total possible score of 15. The Glasgow Coma Scale can help healthcare providers assess the severity of a patient's condition and determine the appropriate course of treatment. Let's take a closer look at each of the individual scoring elements. First, you can observe the patient's eye opening. If their eyes open spontaneously, they get a score of 4. If their eyes open only to verbal stimuli, they get a score of 3. If they only open in response to painful stimuli, they get a score of 2. And if there is no eye opening, they only get a score of 1. Next, we'll look at their verbal response. If the patient is oriented, they get a score of 5. If they are confused, they get a score of 4. If their response includes inappropriate words, they get a score of 3. And if it includes incomprehensible sounds, they get a score of 2. And if there is no verbal response, they get a score of 1. Then you must assess their motor response. If they are able to obey commands, they get a score of 6. If they move in response to painful stimuli, they get a score of 5. If they demonstrate withdrawal from pain, they get a score of 4. If they demonstrate abnormal flexion to pain, they get a score of 3. If they demonstrate abnormal extension to pain, they get a score of 2. And if there is no movement or motor response, they only get a score of 1. Again, the lowest possible score is 3, which occurs in patients who are completely unresponsive, while the maximum score of 15 occurs in patients who are fully responsive. If the patient's score falls anywhere in the middle, you can use the score to classify the severity of their brain injury. For example, a mild injury would get a Glasgow Coma Scale of 13 to 15. A moderate injury would have a score of 9 to 12. And a severe brain injury would have a score of 8 or less. If you want to support the channel, be sure to like and subscribe. I would greatly appreciate it. And there should be some other helpful videos popping up on your screen right about now that I think you will enjoy. And just a quick reminder, we are not doctors. This video...
Okay. So one of the ways that I always remembered, like, the corticate and just decerebrate posturing is core, you come into your core, you flex, and decerebrate has more ease in it, right? So you extend, okay? That was a helpful tip. Okay. So there's a different classification of these levels of recovery as well. Do we need a break before we do this? Yeah, let's take one real quick.